Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Fodden. I'm one of the chairs and organisers of Grand Rounds, and this is the final Grand Rounds of 2022 and of the autumn semester. So it's been really, it is a walk this tightrope through the year of, am I going to have enough people to fill in Grand Round slots, and am I going to have to take out my back pocket and talk about an exciting bit of respiratory medicine? But I haven't had to do that this semester, which is, I think, probably a relief to everybody. And I've had lots of people volunteering to come and speak. And today we've got return business. So Tony Nicoll and David Baty, they presented at Grand Rounds in 2019, which will be frighteningly enough 4 years ago, very soon. And they talked about the initiation of screening for fetal aneuploidy in Tayside. It was a nascent service, non-invasive prenatal testing for trisomy, Downs, I think, initially. And they talked, it was a very exciting talk about how we might expand this into the future and become a leading centre in Scotland. So Tony and David are back, and they're going to talk about what's happened in 4 years. And I may have had my life completely overtaken by COVID in the last 3 years. But things have been happening and progress has been made. And Tony's going to talk to you initially about how the service was set up, where we've got to now, and what the future might bring. And then David will finish us off. As usual, questions in the chat, please. We'll get to those at the end. I think everyone is muted apart from the speakers. Looking forward to hearing you talk, Tony and David. Thanks very much.
Okay, thank you, Tom, for that introduction. I'm Tony Nicoll. I'm a consultant obstetrician here in NHS Tayside, and I'm clinical director for women's services within NHS Tayside. And I'm joined today by David Baty, who is a consultant clinical scientist and the laboratory lead for genetics within NHS Tayside. And so I'd just like to start by thanking Tom for asking us to come back and share our experience of screening for fetal aneuploidy within NHS Tayside. As Tom has alluded to, a lot has happened since I last spoke at the Grand Round back in January 2019. Maternity services, like everywhere else, had severely impacted by the COVID pandemic, but for maternity, we couldn't step anything down. We had to provide our normal maternity services as well as make changes as a consequence of the COVID-19 pandemic and care for women and their families who were affected by COVID. Despite all of that, the National Screening Division of NHS Scotland continued their development to make changes to the screening programme. And right in the middle of the pandemic in September 2020, they launched their new model of screening for fetal aneuploidy across Scotland. And that was very much informed by the work that we had done within NHS Tayside previously. At the last Grand Round, I spoke about the challenges in screening and the development of an introduction of non-invasive prenatal testing in Tayside. And the data that I shared with you previously was used to inform the National Screening Division plans for screening in Scotland. And they introduced a screening service that included NIPT as a second line screening service, as I said, back in September 2020. There are also other changes, which I'll speak about later in the talk. Changes, previously we screened for Down syndrome only, but we now screen for trisomy 13, which is Fetal syndrome, and trisomy 18, which is Edwards syndrome. And we've also made changes to screening for twin pregnancies for fetal aneuploidy, offering women with twin pregnancies the same opportunity for screening as those with singleton pregnancies. Within that time, Dundee was actually selected as the national centre for NIPT. So anyone that has NIPT within the NHS in Scotland is part of it, is following on from a high chance primary screening test. That sample will come to Dundee for analysis. And that's what David's going to talk about. He's going to give the laboratory perspective on the changes that have happened to the national screening programme. But I'm really here to share our clinical experience of using NIPT and how we've responded to those changes. And so that's what I'm going to share with you today. So before I come on to talk about our experience, I thought I would just give a quick overview of how we got to this position where we are. And there's quite a lot on this slide, but if I start in the top left-hand side, we know that as you get older, you are more likely to have a baby that's affected with aneuploidy. If we look on the top left here, we can see how the incidence of the three most common trisomies, that is trisomy 21, Down syndrome, trisomy 18 is the blue line, and trisomy 13 is the green line. And we can see that as a woman gets older, her chances of having a baby with these three conditions increases significantly. Now, the only way of diagnosing whether or not a baby has any of these conditions at the moment is to perform an invasive test. You need to sample the placenta, which is chorionic villus sampling, and that can be done between 11 and 14 weeks gestation, or you can take a sample of amniotic fluid from 15 weeks gestation, a procedure called amniocentesis. Now, these procedures are diagnostic, but they are not without risk. And the main worry that we have and our patients have is that there's an associated risk of pregnancy loss associated with these. The risk of miscarriage from both of these tests is probably lower than we previously thought. We used to quote a risk of 1 to 2% for CVS and 0.5 to 1% for amniocentesis. But the most recent evidence says that for a normal, healthy pregnancy, which is not affected with aneuploidy, your procedure-related loss is probably about 0.5% or 1 in 200. Nevertheless, there's still a risk of miscarriage, and there's also the financial implications of these invasive diagnostic tests, as well as the anxiety that's generated by having these tests. If we offered these tests to women based on age alone, assuming that a woman is high risk of having a pregnancy with fetal aneuploidy at the age of 35 or more, then the sensitivity of that is only about 30%, because most pregnancies occur in a younger population, so therefore there will be more babies with fetal aneuploidy in that younger population. But historically, that's how we screen for fetal aneuploidy. We based our screening on maternal age. But as obstetrics developed and we developed our understanding of fetal aneuploidy, we became aware that fetal aneuploidy was associated with biochemical abnormalities. And in the 80s and 90s, we started to offer screening using biochemical markers for Down syndrome. And that is HCG, AFP, and unconjugated estriol. And that led to a detection rate when we offered amniocentesis to those with a high chance result. Initially, it was 1 in 250. That led to a detection rate of about 60%. But then we moved into the next millennium. And if we go to the middle of the slide, you can see an ultrasound image here. And if you look towards the bottom of that image, you can see a dark space in between two light lines. That's the Nicoll translucency. So if you're performing an ultrasound scan between 11 and 14 weeks gestation, this is the view. You take a sagittal view of a baby and you can measure that Nicoll translucency. And if we come down to the bottom left of the screen, we can see that the higher the Nicoll translucency, the more chance there is of a baby having a chromosomal defect. So at 3.5 millimeters Nicoll translucency measurement, you have a risk of about just over 20%. Whereas if you get up to 6.5 millimeters, your risk is about 2/3 or so. And then we realized that there were other biochemical markers that were associated with fetal trisomy 21, such as PAP-A. And so this led to the development of using combined screening, that is using the maternal age, using the Nicoll translucency measurement, and using biochemical markers. And that was where we were with screening for first trimester screening for Down syndrome up until 2020. So up until that point, we offered women an opportunity to have first trimester screening using these indicators, as I suggested. But we also offered second trimester screening using the triple markers, and we added Inhibin A to that. And that was offered to women who booked too late to have first trimester screening, or who we couldn't perform first trimester screening. Sometimes it's difficult to perform Nicoll translucency, either due to the character of the mother or the position of the baby. So that is where we were. But if I bring you onto this slide, you can see that these tests were certainly better than the sensitivity that was associated with maternal age and the sensitivity associated with biochemical screening. but they weren't perfect. And although the sensitivity was higher, so if you look at the combined test for Down syndrome, that's the first trimester screen using ultrasound, biochemical markers and maternal age, we see we've got a sensitivity of 84% with a specificity that's much higher at 98%. But the problem with these tests is if you look at the positive predictive value, we've only got a rate of 10%. So that means 9 times out of 10, your baby doesn't have the condition that you're screening for. And the only way, as I said, of diagnosing these conditions is to perform an invasive diagnostic test. And so you're performing an invasive diagnostic test, or you're offering it to women when their chance at that point is potentially 10% or so. With second trimester screening, the results are even less. You've got a sensitivity that's under 80%, with a positive predictive value that's lower. So the worry with this was that you had a lot of women who were getting offered invasive testing and uptaking invasive testing, but actually these women potentially were at risk of procedure-related loss because, as I said, amniocentesis and chorionic villus sampling are both associated with miscarriage. So this led to us back in 2014, so we're going back quite a while. We recognized that offering all of these women invasive diagnostic testing perhaps was associated with a risk, and there were also financial implications, and there were also challenges. And actually, you need to be trained to perform invasive diagnostic testing as well as trained to perform nuchal translucency scanning, and there were real challenges providing the screening service in that form. So that led us to look for alternatives. And since 2010 or so, there has been commercially available non-invasive prenatal diagnostic testing. And this is a test that uses or allows us to examine fetal DNA that's circulating in the maternal circulation and allows us to identify babies that have these underlying chromosome disorders. So we know that from early pregnancy, from about 4 or 5 weeks, you can identify fetal fragments of free fetal DNA floating in the maternal circulation. These elements of DNA are not from the baby, they're from the placenta, so they arise from trophoblast. And what's interesting and useful about these pieces of DNA is that they're specific to the index pregnancy, to the current pregnancy, so they appear very early on, but they're also cleared within hours of the birth of the baby. So if you've had a pregnancy before and you come back for your next pregnancy, the DNA, the free fetal DNA that's circulating at that time is specific to that pregnancy. And it reaches a level that's useful for us at around about 10 weeks gestation. So although we can detect it early on, about 10 weeks gestation, we're able to analyse that. And this has led to the ability to detect whether or not a baby has Down syndrome or now other trisomies such as 13 or 18. Without doing invasive diagnostic testing on all women, including those that don't have the chromosome abnormality. So we know that NIPT for fetal aneuploidy and in particular Down syndrome has a high sensitivity. The box down at the right bottom corner of this screen relates to a systematic review that was published back in 2017, and that informed the decision to introduce NIPT in NHS England and also in NHS Scotland. So we know it's got a high sensitivity. At that time, it was thought to be more than 97% for Down syndrome. Perhaps now it's even higher, and David might comment on that, with a low false positive rate. But it's still a screening test because there is still the possibility of false positive and false negative results. And it does require an invasive test to confirm if any decision is going to be made in terms of how that pregnancy is going to be managed. It does have the potential to detect not only Down syndrome, but trisomies 13 and 18. And you can see there the sensitivities and the performance of these tests. It's slightly lower than that for trisomy 21. But the main benefit of this test, which I discussed in the last presentation, was that it allowed a reduction in invasive prenatal diagnostic testing, a reduction in cost, a reduction in maternal anxiety, and also a reduction in procedural-related losses. So that was something that we were very keen to adopt. And back in 2015, we were thinking, how could we adopt that test? How could we incorporate that into our clinical practice? without going against national recommendations for screening, because the screening recommendations from NSD at that time were to continue to offer combined ultrasound screening in the first and biochemical screening in the first trimester, and then biochemical screening in the second trimester. So we approached Lynn Chitty and the RAPID group, who work in St George's Hospital in London, and we asked if we could collaborate in the RAPID study. So the RAPID study was a study looking at how NIPT could be incorporated into the current screening programme. And it was looking to see, could it be incorporated as a second-line test, and would that be a cost-effective test and lead to a reduction in invasive prenatal diagnosis? The questions we were asking were basically going to be addressed by this study. So the team kindly agreed to allow us to collaborate with them, and we got involved in this study, and this study was published in 2016. And the conclusion from that study was that NIPT as a second-line test can improve quality of care and provide better care for women and their families, and improve performance within the current service budget. It demonstrated that at a level of 1 in 150 risk from a primary screening test, that NIPT was cost effective. And so we were keen to continue with that afterwards. This is our data from the RAPID study. The numbers are small. We only collaborated for 6 months or so. We only joined this study towards the end of it, but we can see that our screening uptake back in 2014, 2016 was quite low, actually. And historically, we did have quite a low screening uptake, with only 56% of our women joining the screening program at that time. We found that 3% of our population were screened positive, but we found that these are women, these 36 women that had a high chance result of having a baby with Down syndrome based on either first trimester or second trimester screening. Out of the 36 women, only 7 of them had invasive diagnostic testing, whereas prior to the availability of NIPT, we suspected all of them would be offered it, and many would take up that offer of invasive diagnostic testing. And 75% of that population elected to have this new test of NIPT, which is the outcomes were actually similar to the whole population that was included in that RAPID group, with an invasive diagnostic test for the whole population of 20% and an NIP uptake of about 3/4. So that was then, we continued to offer NIPT. We managed to source funding for that, and we continued it for another 12 months or so beyond the RAPID, and that's what I shared last time. But then we stopped doing that because it was felt that there was an imbalance between what we were offering in NHS Tayside and elsewhere in the country. But we did continue to look at our screening outcomes for our population, and this is what I presented last time as well, that back in 2017, 2018, we had a much higher screening uptake of almost 70%. The national uptake was published in the RAPID study was about 75% or so. So we were heading towards that. Our false positive, our screen positive rate was 2.2%. What was interesting, that out of our women that screened positive, less than half of them were going for invasive diagnostic testing, and still a significant proportion of women were going for no test. And remember, most of these women, 9 out of 10 of them, will not have a baby with Down syndrome. So about a third of them were not having any further test with that knowledge. But we weren't offering NIPT at that time, but our women were choosing to have NIPT themselves. As I said, it's been commercially available since 2010. So about a third of our population, when they had a high chance result, they'd seen the results of the RAPID study or were aware of that, and they'd elected to have NIPT independently, and they were self-funding that, and that was allowing them to make choices about their pregnancy. So that's where we were. Now, following on from my presentation, there was a number of short life working groups within the National Screening Division of Public Health Scotland, and they were looking at what changes they could make to the pregnancy screening programme, including adopting NIPT as a second line test, with the knowledge of the RAPID study and the work and experience that we'd had within NHS Tayside. And these changes were implemented, as I said, right in the middle of the COVID pandemic on the 28th September 2020. And so the changes were that we, in addition to screening for Down syndrome, we were able to offer women screening for trisomy 18, which is Edwards syndrome, and Fetal syndrome, trisomy 13. but only in the first trimester. So anyone attending for first trimester screening, they got a choice to screen for either Down syndrome or Down syndrome and Edwards and Fetal syndrome, or Fetal syndrome and Edwards syndrome only, or not to have any screening at all. NIPT was incorporated into the national screening programme as a second line test. So not as a first line test, because this was not felt to be cost effective, but as a second line test as an alternative to invasive diagnostic testing. And as I mentioned earlier, there was an update for screening for twin pregnancies. So women with twin pregnancies historically could only have first trimester screening using Nicoll translucency. But following the changes in September 2020, women could have either first trimester screening for trisomy 13, 18 and 21, or second trimester screening for trisomy 21, in line with what happened for singleton pregnancies, accepting that the screening test performance for multiple pregnancy is about, for sensitivity, about 8% or so lower than it is for singletons. So this is where we are now. David is going to show something similar later with a lot more detail, but as a clinician, this is how I look at the screening program for fetal aneuploidy. So we screen for trisomy 13, 18 and 21. In the first trimester, that's biochemical screening for all three. And in the second trimester, that's screening for trisomy 21 using biochemical testing. And this applies to singletons and twins. If you have a high chance result, that's a risk greater than 1 in 150, then we offer either invasive diagnostic testing, NIPT, or expectant management. And if you have a low chance result, then we do not offer any further testing. And accept that there will still be some women who are not reassured and who either self-fund NIPT at that stage or request amniocentesis, and we'll have that discussion with them. If you do have NIPT based on high chance primary screening, then we will offer invasive diagnostic testing. But as you'll see from this, many women choose not to have invasive diagnostic testing for a number of reasons. And if you have a low chance NIPT result, then you get the same option. You will be, as a low chance primary screening result, we will say, you're low chance, we don't offer further testing, but some women may request that testing anyway. So there's a national evaluation of the changes that's taking place, but it's not due to take place till September 2023, but we have local data, and this is what I'd like to share with you today. So we have made these changes, we've implemented these changes, and what we wanted to look at was, did it have any effect on our uptake for screening? Did it have any, what was the uptake for NIPT? I mentioned before, it was 75% of our population in the RAPID study. How did NIPT perform? Did we have any false positives or false negatives? And what was the impact on invasive diagnostic testing? And what was the impact on Down syndrome births? When we were doing the short life working groups for introduction of NIPT, there was concern raised from a number of groups, including Down Syndrome Scotland, that introducing or making these changes to the screening programme might actually reduce the number of babies with Down syndrome that are in our population. So we thought we would look at that and see whether or not that was the case. So when we've presented this before, we looked at 18 months worth of data. And so I thought I'd look at 18 months of data from 2021 to 2022, so January 2021 to June 2022. And using that 18-month population, we have outcomes for most of these as well. So these were women having tests towards the end of the first trimester. So the majority of these patients are delivered, so we know what the outcomes are. Within that time period, we had 5,799 women who booked with us. And in that population, we had 710 non-continuing pregnancies in the first trimester. So that's around about 10 to 15%. Pregnancy loss in the first trimester is somewhere between 10 and 20%. So that's consistent with that. But we're perhaps seeing more because we're booking women a lot earlier now. Women are coming to see their midwife and getting an electronic record created almost as soon as they've had a positive pregnancy test. So that might explain why our miscarriage rate for this population is certainly consistent with published data out there, but it does seem slightly high. But I think it is reflecting what is actually going on in the first trimester and reflecting good data collection. We did have 5,089 women who were eligible to participate in our first trimester screening programme. And this includes 62 women with twin pregnancies who could have participated in this screening programme. So in terms of the uptake of screening, well, we had 4,307 women that participated in the first trimester screening program, or sorry, the screening for aneuploidy, fetal aneuploidy program, a rate of almost 85%. So this is certainly much higher than the rate in 2015, which I quoted just 56%, and again higher than the rate in 2017, 2018, where we were just under 70%. This is interesting, and there is certainly a change in behaviour, and I wonder, I think it's multifactorial, whether it's due to perhaps women perceiving they've got a lower chance of needing an invasive diagnostic test, because that seemed to me the reason why many women would choose not to have first trimester or primary screening for fetal aneuploidy. But I also think it reflects the education that took place around the launch of the updated screening programme in 2020. Every health professional working with maternity had to enrol for training, national training via TURAS. And I think there's a greater awareness and understanding about what screening is. And I think women are better informed now as a result of that. And so that's perhaps why there's a greater uptake of screening. It is interesting that a significant proportion of our women had second trimester screening. So these are women, most of our women book before 12 weeks and therefore would be eligible for first trimester screening, but a significant proportion, just over 20%, had second trimester screening for trisomy 21. And I think that reflects the way we were working at that time during the COVID pandemic. This 18 months of data occurs during COVID, and particularly back to January 2021, where we weren't able to offer our ultrasound service in the usual way, and that had an impact on how we were able to offer screening for trisomy 21 and other trisomies in the first trimester. Our screen positive rate was broadly similar to what we had before. The national rate is between 2 and 3%, so we had a screen positive rate of 2.85%. And we had 83 women who had a first trimester high chance result, and 4% of second trimester screens had a high chance result. So leaving 123 women who had a high chance screening result. Of these 123 women, we had 118 singletons and 5 twins. And as I said, 83 were in the first trimester and 40 were in the second trimester. The majority of these screened positive for trisomy 21, but we did have 10 women that screened positive for 13 and 18, and of those, 5 of those were screened positive for all 3 trisomies. So it was an interesting observation. So we had this 123 women that had a high chance primary screening result for fetal aneuploidy. And if you remember back in the RAPID study, about 75% went for NIPT. So now we find that 114 out of 123 women elected to have NIPT, a rate of over 90%, which is much, much higher. Almost all of our women had NIPT. There were still some women who decided not to go for NIPT and would prefer to have invasive prenatal diagnostic testing. So these are women who perhaps wouldn't have been reassured by NIPT and wish to have direct confirmation. And then we still had some women who decided that they didn't want to have any further testing and declined NIPT and declined invasive diagnostic testing as well. We had one woman who who had private NIPT prior to first trimester screening, so she decided not to do anything. This is often the case. Women get offered NIPT via a variety of different sources. Women who have IVF get offered NIPT as part of a package of their IVF. And I think this is one woman who had NIPT but hadn't declared it and enrolled in the first trimester screening program. And then when she had a high chance result, we told her about NIPT and she said she'd already had that, so didn't need any further testing. And that baby was fine, didn't have Down syndrome. So how did NIPT perform? So we had 114 women that had NIPT in our 18-month period. Of these, we had one unsuccessful test. We just couldn't, and this is a recognised feature of NIPT, that you may not have enough fetal fraction. And so this woman elected to have invasive diagnostic testing rather than repeat testing. But this gave us 113 results. Out of the women that had NIPT, 16 had a high chance NIPT, a rate of 14%. And David might say something about that later when we compare that to the national rates of positive NIPT. Of the 16 that had a high chance NIPT result, 11 went on to have invasive diagnostic testing. And of the 5 that didn't have any further testing, 4 of them had trisomy 21. And there's one that we don't have an outcome for yet, or a confirmed outcome, because this woman is still pregnant and she's approaching the end of her pregnancy. For those with known outcomes, so that's all 15 who we have outcomes for. So the 11 that had the diagnostic testing and the 4 of the 5 that had no further testing, all of these had fetal aneuploidy, whether it be 13, 18 or 21. And of the 97 out of the 123 that had a low chance NIPT, none of these babies had aneuploidy. So looking at this, we've not had a false positive in our population, and we've not had a false negative either. And I guess that's to be expected with the small numbers, with the high sensitivity and the high specificity. But it is reassuring that this is how it's performing in our local population. Just very quickly, I'll go through twins. I said we have offered twins now as screening in the same way that we offer it to singletons. And we had 5 out of 62 had a high chance of primary screening. And 4 of these had NIPT, and we had 1 baby in that population that had suspected trisomy 21. Performing invasive testing on twins is not without risk. You're doubling your risk of miscarriage. It is challenging. It's something that we refer elsewhere for because of the higher risk when you're performing these tests. And none of our group had invasive testing. So in our twin population, we had 1 baby with confirmed Down syndrome after birth, but 9 out of 10 had normal chromosomes. So in our population of 123, if we think historically, these are 123 women with high chance either first or second trimester primary screening results, who in the past we would have offered invasive diagnostic testing. And we see that only 12% of women had invasive diagnostic testing. So 88% of women avoided a procedure that was associated with anxiety, associated with cost, and associated with potential unintended pregnancy loss. The women that had invasive testing, we had 11 of these that had a high chance NIPT. We had 3 women that opted for diagnostic testing rather than NIPT. And we had our other women that had an unsuccessful NIPT who had that test. And her risk was 1 in 143, and her amniocentesis was negative. So what about the impact of NIPT and the changes to the screening program on invasive prenatal diagnostic testing? So I presented a slide similar to this last time, and we can see as we go through, we have about 50 to 60 invasive tests a year in NHS Tayside. And if we look at 2015, 2016, the 2 years where we were previously offering NIPT, we can see a reduction down to between 30 to 40 invasive diagnostic tests. We've got amnios in yellow and CVSs in pink, with the total invasive tests in blue. And thereafter, when we withdrew NIPT, we can see a rise back up to the background rate of 50 to 60. And then if we look at the last 2 years, and these are data for 2021, 2022, right up until this week, and we can see that we're back down to having 30 to 40 invasive diagnostic tests. And I think this does reflect what's happening with NIPT. It's given women that reassurance that they don't need to have invasive diagnostic testing, and that NIPT is reliable when it's negative and when it's positive. Just very briefly, we had 16 babies identified by screening, 2 with trisomy 13, 2 with trisomy 18, and 7 with trisomy 21. And these women all opted for termination of pregnancy. But we had 5 with suspected trisomy 21 that continued. I said we've got 4 babies that have been born with confirmed trisomy 21 and 1 that's still continuing. So if you have a diagnosis of trisomy 21, we're seeing that women are continuing with their pregnancy, and they're not all opting to end their pregnancy, as was perhaps suspected by some of the working parties or the groups that were on the working groups for introducing NIPT. And if we look at what's happening with Down syndrome, we had 17 babies with confirmed trisomy 21. And just over half of them opted to have a termination of pregnancy, but 4 of them continued with their pregnancy. We had, unfortunately, 4 babies that were diagnosed at birth, and of those, 2 of them had declined participation in the screening program. But we had 2, unfortunately, had low chance primary screening. But it's important to be aware that low chance primary screening, it's not no risk, but the risks were really low in this situation, 1 in 3,000 and 1 in 18,000, but it doesn't absolutely mean no risk at all. And again, coming back to what was the impact on Down syndrome births, and if we look at the numbers, We had 8 births in an 18-month period, so around about 5 or 6 a year. And that broadly is in keeping with our historical rate of Down syndrome within NHS Tayside, with between 3 and 7 babies per year born with Down syndrome on average. So in conclusion, what we can see since we made these changes to the screening programme is that there's been an increase in the uptake in screening for fetal aneuploidy. We're now sitting at over 80% uptake for fetal aneuploidy. We know that NIPT is acceptable and reliable in our population when it's used as a second-line screening test for fetal aneuploidy. And we know that that test, since we've introduced it, has been shown with a reduction, it's been associated with a reduction in invasive diagnostic testing. And what is reassuring is that there's been no reduction in the number of babies born with trisomy 21 and Tayside. So just to finish off, I'd like to thank my colleagues who work, the healthcare assistants and midwives that work alongside me in the fetal medicine unit in NHS Tayside. Kerry and Gillian spent a lot of time collecting this data contemporaneously and put this together, or helped me collect this data and collate this for this presentation. And Leslie is our senior fetal medicine midwife, who again provided support for this presentation, but also provides support. All of these individuals provide support for our women that are identified as high risk of screening or high chance from screening, and help out with their counselling and ongoing care. So I'll stop there and I'll stop sharing my screen and pass on to David now. So I'll look out for any questions in the chat and I'll answer them at the end. But thank you very much for listening to that. So it's over to you, David.
Thanks, Tony. David, there you go. He's sorting it out. It's all good.
So can everybody see that presentation?
We can. If you
right. Okay. Well,
if you click on your presentation button, we'll see if it goes full screen.
Okay. Is that all good now?
No, we can still see the desktop version.
Right. I might just have to go with that, actually.
Okay, that's all right. So we can't see your emails or anything, so we're okay.
Perfect. Okay, so so thanks very much, Tony, for introducing the clinical side. My name's David Baty. I'm consultant clinical scientist and head of lab in NHS Tayside in genetics. What I'm going to do is I'm going to be very quickly just kind of follow on from what Tony's presentation and outline that the data that we've collected or gathered following 2 years of offering the NIPT service, screening service from Dundee. So is that moved on okay? Yep, okay. So this is really a sort of timeline in terms of how we established NIPT in Scotland. And as Tony said, it was part of a 3-year evaluation of NIPT in Scotland, following a recommendation from the National Pregnancy Screening Programme and the UK National Screening Committee. And the process started in March 2018 and went through a formal tender process in 2019, which led to the identification of the Illumina VeriSeq NIPT solution being the sort of preferred testing option in September 2019. And we basically had to go through, the laboratory in Dundee had to go through a sort of competitive tendering to actually be awarded the service, and that was duly awarded to us in February 2020. So we became the designated screening service for Scotland. Obviously, COVID was ongoing during 2020, so the planned go-live date was for June 2020, but that was pushed back because of the logistics and the difficulties in terms of COVID. So we decided to push that back until September 2020. And we went live on the 29th of September 2020 with the NIPT screening service from Dundee. It's worthwhile noting that there's been other UK NIPT evaluations as part of the UK Screening Committee. Wales started in April 2018, and England just started in June 2021. So Scotland kind of sits in the middle of these two ongoing evaluations. And the idea is to gather data across the sites in the UK that are offering NIPT to come up with a UK evaluation of the effectiveness of NIPT. So as Tony said, he introduced the sort of new screening pathway, and this is just a bit of an expanded testing pathway, but it really shows that as from September 2020, there was another option available rather than following a higher chance screen. So you have, obviously, you can still have the options of taking no further testing or going direct to a invasive diagnostic procedure. But now women have the choice of undergoing NIPT as a secondary screening test. And you can see the various pathways and choices available there. So in terms of the acceptance criteria for being offered NIPT as a secondary screening, obviously it follows a higher chance, greater than 1 in 150 of T21 or T13, T18 from the serum screening. As Tony said, NIPT is, although the free fetal DNA can be detected as early as 4 to 5 weeks, NIPT is only offered after 10 weeks gestation. In addition, what we're doing is we're accepting referrals that come through clinical genetics if women have had a previous trisomic pregnancy for either T13, 18, or 21. And we're also offering women who have missed the opportunity through no fault of their own to undertake for either first or second trimester screening. We're also offering NIPT for those cases as well. Although the current recommendations from the Scottish Screening Committee is that we should really be invoicing the host board for these tests for these ladies. And in terms of the inappropriate referrals or referrals that NIPT is not appropriate for, obviously if women haven't gone through the approved national screening pathway, or if there's a sort of fetal abnormality in terms of the detected in the early pregnancy scan, or indeed if there's an evidence of a vanished twin. Maternal transfusion, transplant, surgery of malignancies can actually lead to false positive, false negatives with NIPT. So if there's any evidence of those procedures, unfortunately NIPT is not appropriate. And also if there's a known maternal chromosome anomaly, and we currently don't offer NIPT for fetal sexing. So this is just very briefly just looking at the benefits and limitations. It's, as Tony said, it's a more accurate test than the primary first trimester serum screening test, and it's got a high sensitivity and specificity. And these are quoted at greater than 99%. There's no risk to pregnancy, and it should lead to a reduction in invasive procedures. And it has been quoted as being relatively cost effective as a screening option. As I said, there is a number of limitations. NIPT, it's important to stress, is a screening test. It's not diagnostic. And NIPT in the mode that we operate or offer at the moment only looks for anomalies of 13, 18, and 21. So it's not intended to detect other chromosomal anomalies or detect polyploidy or balanced translocations. We currently offer it for singleton and twin pregnancies, so not suitable for higher order pregnancies. And it should be noted that there is the risk of false, or the chance of false positive and false negatives, and largely that's due to a number of factors. But one thing that you have to be aware of is that the origin of the circulating fetal DNA is actually comes from the cytotrophoblast. So it is classed as fetal, but it's of a different embryonic origin than the fetal. And you can detect or identify or be affected by placental mosaicism. The other thing to note is that low fetal fractions can actually result in an inability to get an NIPT result. So this is very quickly, this is the sort of timeline from clinic to report. We're currently recommending across Scotland that samples are taken in clinics on the Monday and Tuesday, and these blood samples are taken in specialised tubes and sent to the laboratory via Track 24 Royal Mail. Obviously, with the current postal strikes and disruptions and delays over Christmas, we are resorting to using courier services for our NIPT service to ensure that the blood samples are reaching us in good time. The laboratory has set a sort of deadline from noon on the Thursday of each week to accept samples. So provided the samples arrive in the lab before noon on the Thursday, that allows us to isolate the plasma from the blood samples and extract the free fetal DNA. And then Friday is very much a sort of laboratory prep day where we're actually doing the testing, and then we're running the samples on the analyzers over the weekend, so that Monday we come in and the results are available for us so that we can issue reports. And the way we've done this is that so we can offer or issue reports within 7 calendar days, and that's the contracted time that we're currently offering for NIPT from receipt of sample to issue of results. Just looking at our reporting times, we're generally reporting within 5 calendar days from receipt of sample, and we're contracted. Well, basically, our performance against these contracted times is greater than 90% of reports issued. So, just very briefly in terms of the test performance, as Tony mentioned, very high sensitivity and specificity for the 3 chromosomal anomalies that we're looking at, both in singleton and twin pregnancies. And again, if you look at the NIPT for trisomy 21 compared to the first trimester screening, you have a very high positive predictive value for trisomy 21 for NIPT compared to the first trimester combined screening in 3 different maternal age groups. So this is just really presenting a sort of an overview of the data that we have to date. And this is over the last 2 years for right across Scotland, from the September 2020 to the end of September of this year. So we've got 2 years of complete data. The one thing that's very frustrating, and it's lovely to see Tony's talk, is that Tony's now is provided us with outcome data for Tayside. We won't be able to see the outcome data, complete outcome data for Scotland until the sort of national evaluation has been done. And the time frame for that is probably going to be completed in 2025 and possibly published in 2026. So we're some time off yet before being able to see both our data for NIPT, for the lab data, but also the complete outcome data. So it's lovely to see Tony's data for Tayside. So in terms of the higher chance referrals, we've had a total of 2,107, and you can see they're broken down by the vast majority of those are singleton pregnancies, and and again, these are broken down into first trimester and second trimester. There's about 3% where the actual whether it's first or trimester is not stated, and again, this is just information that we're we need to collate. Looking at the screen positive rate, so this is basically a high chance NIPT result from a higher chance referral from serum screening. We're currently running nationally at 7.6% of higher chance referrals have a high chance NIPT for one of the 3 chromosomal anomalies. And again, as Tony said, the Tayside data is running about 14% serum positive rate. So screen positive rate. So Tayside's roughly almost twice as high as the sort of national Scottish rate, which is something of interest. And again, you can see that of the high chance NIPT results, the vast majority, as you would expect, 74%, are due to T21. We've got a very low failure rate, and you can see that only 10 out of over 2,100 referrals, actually, we failed to get an NIPT result. And this is even after repeat testing on the original sample, or indeed offering a repeat sampling, another blood sample that we've subsequently tested. I suspect that the majority of this is probably down to low fetal fractions although that's something we need to dig into. And the number of samples that were rejected in which no NIPT testing was undertaken was 33, and this is probably due to either the wrong blood sample or delays in getting the blood sample to us, or some other reason. So that's the vast majority. But again, it's only 1.6% of referrals we couldn't actually offer testing for. If you look at the previous trisomies, these are in total, we had 256, and you can see that 2% of those referrals where there was a previous trisomic pregnancy, we detected an anomaly by NIPT, and you can see there's the breakdown. And the missed screens, we had a total of 8 missed screens that we offered over the last 2 years, and we didn't detect an anomaly in any of those missed screens. One thing to note is that, as Tony mentioned, there is the risk of, or the chance of, false positive and false negatives by NIPT. And in total, we've identified 1 false negative, which was a low chance in NIPT, which excuse me, turned out to be a trisomy 18 on amnio. Interestingly, this lady had a CMV infection, and there is some evidence that high CMV infections can actually alter or affect the results from NIPT. Alternatively, this could be a result of a mosaicism. So we also had 3 false positives. So there was 2 trisomy 18 and 1 trisomy 21. And so by looking at the amniocentesis results and comparing it to the NIPT, the most likely explanation was that these false positives were down to confined placental mosaicism. So for all the false negatives and false positive results, we have a reasonable underlying biological reason for these results. So one of the things that I just wanted to touch on very briefly was the key findings from Wales. So Wales are, because he started in 2018, and they've actually just published in prenatal diagnosis this year. And Wales also have good outcome data as well as the laboratory data. So again, just very briefly, they had a high uptake in terms of the number of women accessing NIPT following a high chance serum screening result. Again, that was 84%. And you compare that to Tayside. I mean, Tayside, we were having a 92% uptake, which again is very good. The screen positive rate for NHS Wales was 6.7%, so it's slightly lower than the 7.6 that we've found to date for Scotland. They had 100% specificity, and they had no low chance NIPT results, or ladies having a low chance NIPT requesting invasive. They had a double the failure rate for NIPT compared to the Scottish data, our data. And the reason I think that that's probably the case is that when we failed to get a result in the primary sample, we did offer the opportunity of getting a repeat blood sample, and then we tested that. In Wales, this didn't happen. So that could account for the slight discrepancy, or their slightly higher failure rate compared to ours. One of the things that is worth mentioning is the evaluation in Wales only really involved singleton pregnancies. And one of the key messages from the Welsh paper was they found an approximately 9-fold reduction in invasive procedures comparing pre and post implementation of NIPT. And again, similar to Tony's findings, there was no significant impact on the live birth rate for Down syndrome following the implementation of the NIPT screening service. So the take-home message is that the data from Scotland compares very favorably to the findings from our colleagues in Wales. So just very briefly, just a final couple of slides, just looking at the referral rates for NIPT. And this is based on data provided by Dr. Lorna Rashid, who runs the serum screening service from NHS Lothian. And we looked at this is the referral rates for NIPT per 100,000 population based on health boards. And you can see that compared to the sort of overall Scottish level, or Tayside, Lothian, Greater Glasgow and Clyde and Grampian all has significantly high referral rates for NIPT. And one of the reasons that we wanted to look at was the higher chance results by health board based on the first and second trimester screening. And again, you can see a similar picture, although Tayside is kind of come down in line with the other health boards, but Lothian, Greater Glasgow and Clyde and Grampian are again all have relatively high referral rates based on their first and second trimester serum screening referrals. and again, this is just another figure, again showing the first and second trimester, and again it's the same sort of pattern that you're getting. So one of the things that we wanted to do was to look at the age profile of our health board. And again, I just want to acknowledge this is the work of Erin Middleton, who was a bioinformatician that spent some time with us and really used our skills to delve into the data in a much greater detail. And Erin's now taken up a position of a trainee clinical scientist with us for the next 3 years. But just want to acknowledge that this figure came from Erin's work. And really, it looks in great detail at the age demographics by health board in terms of the sort of the different age ranges by health board based on the referrals that came in for NIPT. And you can see that again, it just kind of backs up the referral data, showing that generally speaking, there's more significantly more proportion of women in the slightly older age groups, but compared to in terms of Lothian, Greater Glasgow and Clyde and Grampian compared to other health boards. So this may account, it may be that the maternal age, increased maternal age may be affecting or influencing the referral rates for NIPT. So again, I'm just conscious that that's my allotted time, and I'd just like to finish by just briefly saying that the future opportunities for NIPT, we're very keen to expand the clinical utility of NIPT or the clinical use of NIPT. As I said before, we'd really like to offer NIPT for any lady who has missed the opportunity for either first or second trimester screening. That should be, NIPT should be offered automatically. And also, there's a good clinical case for offering NIPT to carriers, women who are carriers of Robertsonian translocations. There's a possibility of widening the eligibility criteria and also the potential to offer screening to women of maternal age. One of the things that we're very keen to do is we're currently running the NIPT in what's termed basic mode, only looking for anomalies of 13, 18, and 21. But it does have the capability, if we run it in genome-wide mode, to look for anomalies in other chromosomes. And there's a potential to perhaps do a sort of evaluation, small-scale evaluation program working with Tony to compare genome-wide screening in NIPT for ladies with AB scans, increased Nicoll, who do opt for the invasive diagnostic procedures. And we can compare array CGH data with our genome-wide from NIPT to see if the results are correlate. There's also the option of fetal sexing, and further down the line, offering NIPT as a frontline screening option. So I'd just like to finish there, and just thanks very much to the NIPT team in Dundee for all their hard work, and also for me shamelessly ripping off some of their slides that they presented earlier. I'd like to thank Tony Nicoll and Leslie Mays from colleagues in Obs and Gynae, and also Dr. Lorna Rashid, who we work very closely with, as I said before, who runs the serum screening service from NHS Lothian. Thank you, and I'll finish there.
Thanks very much to both David and Tony. We're right on the limit of time here. There's a comment and a question. Sarah Martin Silva has just said as a comment, NIPT is not offered as part of IVF. Tony, can you perhaps just expand on why?
Yeah, no, I perhaps misspoke when I said that. What we're seeing is that women that often have private procedures elsewhere, not necessarily in the UK, they have more of awareness of NIPT, and that's maybe leading them to have that procedure independent of the screening programme that we're offering within NHS Scotland. So I'm sorry to say if I caused any offence by suggesting that it was being offered inappropriately as part of a package.
There you go, that clarifies that. We're all friends here. And then Ron Kerr has said fetal sexing would be helpful for haemophilia carriers. Ron and I were having a corridor conversation just on the way to Grand Rounds today, just talking about this. David, I don't know if you've got any comment.
Yeah, again, we've had fetal sexing's pretty high on our list of our wish list, and again, we've been having discussions with our clinical genetics colleagues who obviously want to extend the use. We're kind of constrained in terms of the colleagues from the screening committee. But we're hoping that we can try and make a good clinical case and persuade them that NIPT should be offered for fetal sexing for these sorts of conditions.
Yeah, I mean, if we're being honest, most of them, as I think was mentioned by Tom at the start, sorry, just coming in, most of the haemophilia carriers want to carry on with a pregnancy. Yep. So the sexing tends to be just done late with ultrasound scanning at 25 weeks, and some of them are quite happy to get an extra scan later on from that point of view. But I don't know, so some of it would become cost effectiveness, because there's obviously a cost to getting extra ultrasound scan. This may eventually become a more cost effective option than
I mean, we're sending, I mean, clinical genetics requests, they're all being sent down to Birmingham, colleagues in Birmingham, for fetal sexing, and there's a cost associated with that as well.
Thank you.
Right, thanks everyone. Track care tells me my first patient has arrived at clinic, so I best go and see them. Thanks again to Tony and David for talking today. Thanks to everyone who's presented at Grand Rounds over the last 12 months. At the moment, we start again on the 26th of January. We do have the slot the week before that, if anyone wants to jump in. We have a slot on the 9th of March, which is empty, and then slots available. I think the 30th of March is available as well. So if you're sat there thinking, I could do this, I've got a great talk to give, whether it is a specialist thing, whether you think it's an update on research, on the latest technologies, future scoping, or whether it's a basic straightforward talk on helping the general physician to know, learn about something like this is, to me, this is well below the diaphragm. So this is all new learning for me. Every time I hear a gynecology talk, it's all obstetrics, it's all new learning. So please don't think that a talk won't be interesting at Grand Round. I can almost guarantee it will be. Please do get in touch. Have a good Christmas, happy holidays. See you next year.
Thank you, Tom.
Thanks very much, Tom.
Thanks, David, as well. It's a good talk. Thank you.
Thank you.